A very good morning to all. I invite Dr. Veena Vaswani to welcome the audience.
Can you hear me?
Yes, yes.
Okay. Good morning to you all. A hearty welcome. I welcome our Chancellor Yenepoya Abdullah Kuni and Pro-Chancellor Mr. Farad Yenepoya, our esteemed Vice Chancellor Dr. Vijay Kumar, our Pro-Vice Chancellor Dr. Shripati Rao, our Registrar of Yenepoya University Dr. Gangadhar Somayaji, our Controller of Exams, Deans of Faculties, Heads of Departments, and a very warm welcome to Dr. Sunil Pandy. Mulya Pravah Task Force has done an excellent job in picking the right person to kickstart the inaugural online lecture series. He is a man who has walked the talk and who has chased ethical values in every aspect of the endeavor, including neurosurgery and day-to-day life and professional life. So without much ado, on behalf of Mulya Pravah Task Force, which is reinforcing values in higher education, and Center for Ethics, with the motto of embedding ethics in every task and every person, I extend my warm welcome and pass on the screen to our most capable registrar, Dr. Gangadhar Somayaji. Over to you, sir.
Madam, thank you and good morning. I hope I'm audible.
You are, sir.
Yeah, thank you, madam. Respected speaker for the day, Dr. Sunil Pandya, the members of the task force for this particular UGC quality mandate, that is Mulya Pravah, faculty members and other interested listeners. A very good morning. As you are all aware, when the lockdown was initiated some March, April of last year, the University Grants Commission came up with so-called the quality mandate. Basically, to retain the morale and the productivity in the academic fraternity, to inspire the faculty to make the productive use of the time during the lockdown period, and also to address certain challenges in higher education institutions, upholding the state-of-the-art curriculum, enrichment and maintenance of quality of teaching, research and other services, adoption of ICT in teaching learning activities, preparing next generation of socially responsible citizens and leaders. In fact, about 11 quality mandates were listed. One among them is this particular quality mandate, that is Mulya Pravah. That time we initiated activities under each of these quality mandates by creating task force with at least 4 to 5 members under each category, and we requested them to conduct activities so that some useful output from these particular quality mandates may be arrived at. In fact, few of the task force leaders have already initiated this process and conducted some activities, and few of them are in the process of doing so. I am very happy that the task force for the Mulya Pravah has initiated a series of webinars this year. And to begin with, they are having a talk from a renowned person, Dr. Sunil K. Pandya, on a very relevant topic, that is the need for a humane doctor-patient relationship. I'm sure the talk will be very useful to all of us. Basically, I'm a person who believes that the strength of the society is dependent on developing a good quality human values and professional ethics. Higher education institutions, they have a major role to play in creation of a healthy society. In fact, if you aim at only the knowledge component, probably the brain of the graduate would be filled with knowledge when he comes out. But if you don't do anything to fill the heart component of the education, probably the universities are not doing their full job. That is what I personally believe. In fact, the organizers have given me 2 minutes to talk. I don't want to be, unethical in, and moreover, the resource person is a well-known person. We are all eager to listen from him, and I wish the program all the very best, and I thank the organizers for giving me an opportunity to be part of this event. Thank you, and I wish the program all the very best. Thank you once again.
Thank you very much, sir, for the introduction to Mulya Pravah, and thank you for giving us the opportunity to take this task forward. And I now have the privilege to welcome and introduce Dr. Sunil K. Pandya, who's the guest speaker for today. And he's like an opening batsman for us, because we are going to kickstart a series of webinars on relevant topics related to Mulya Pravah. So I'm very happy that he has agreed on our request, and he has come forward with a very relevant topic for today, that is the need for humane doctor-patient relationship. So let me introduce him. He's an alumnus of Grant Medical College and Sir J.J. Group of Hospitals, Mumbai. He obtained his MBBS from the University of Mumbai in the year 1961 and MS in General Surgery in 1965. His training in neurosurgery was under the guidance and supervision of Dr. Gajendra Singh at JJ Hospital and Homi Dastur at KEM Hospital. He further pursued specialty training in the Institute of Neurology, London, with Professor Valentine Loeb, and in the Institute of Child Health at Great Ormond Street, London, with doctors like Kenneth Till and Norman Grant in 1974-75 as a Commonwealth Medical Scholar. He was appointed Professor of Neurosurgery at Seth Gorandas Sundardas Medical College, that is GSMC, and King Edward VII Memorial College, that is KM Medical College, Mumbai, in 1975, and retired on superannuation in 1998. He has published in scientific journals as well as popular press on neurosurgery, the history of medicine, and issues pertaining to ethics in medicine. He is the professor emeritus editor of the Indian Journal of Medical Ethics and serves on editorial boards of medical journals and men's Sana monographs. He's also a member of Division of Humanities at KEM. So this is one of the felicitations that was written by Dr. Amar Jasani in IJME on to felicitate Dr. Sunil K. Pandya. So we welcome you, sir, and over to you for the talk. Thank you very much.
Thank you. Thank you very much, Dr. Kulkarni. I am also grateful to the task force, the Mulya Pravah task force, and Dr. Veena Vaswani and the registrar, Dr. Gangadhar, for your kind invitation to be here and discuss a very important aspect of the relationships between medical personnel. Although the title says a doctor-patient relationship, the principles apply to nurses, physiotherapists, occupational therapists, and anyone else who has to deal with patients. So let us start first of all with the doctor-patient relationship and why this is important. Why is a medical personnel or paramedical personnel and patient relationship important? Many centuries ago, the person who is now acknowledged to be the founder of medicine, in the West at least, and that is Hippocrates, he had written that wherever the art of medicine is loved, there is also a love of humanity. So unless there is a love of humanity, we cannot really practice the art of medicine. And without the art of medicine, the science of medicine is incomplete. Why is this discussion necessary? Because the current situation in India is somewhat demoralizing as far as training of paramedical and medical personnel in ethics, in philosophy, in humanities, and the history of medicine is given the go-by. In fact, in many medical colleges in India, these are not considered at all as part of the training of an undergraduate or a postgraduate student. Fortunately, we have some exceptions, and I've listed these exceptions at the bottom of this slide. It is important for us to define the terms that we use so that we are very clear about what we are talking about. The word human is derived from Latin, and the word human connotes that the individual who is classified as human has an inherent sense of right and wrong. It is built into the consciousness of this person, the ability to distinguish between right and wrong. And this distinction of right and wrong is based on reason. There is a rationale for calling something right and for calling something wrong. And I think this is actually present almost from infancy, but it develops as the infant becomes a child and as the child grows into a young adult. And much will depend on the kind of training that is available to this person at home, in school, and in college. The word humanity is derived from the Latin humanitas, for human nature, and it is characterized by kindness, by affection, sympathy, empathy, and harmony. There are other characteristics also, but these are the crucial characteristics. Now, I'd like to make a distinction between sympathy and empathy. Sympathy is what we feel when we see another individual in trouble. So, for instance, if I'm walking down the road and I see a person who is in tatters, I feel sorry for him because he doesn't have clothes to cover himself adequately. Empathy, on the other hand, is putting yourself in that person's position and actually experiencing what that person is undergoing. So if I have a patient on a bed who has got acute pain in the right iliac fossa because of appendicitis, I can actually feel that pain in my iliac fossa because of this quality of empathy. And you can understand that the quality of empathy will ensure a much, much stronger activity, which will help the individual that we are considering rather than mere sympathy. What is humaneness? Humaneness describes an individual action which contains all these characteristics that we have defined above: kindness, affection, sympathy, empathy, harmony. And all these criteria will engender in a humane individual the quality of compassion. You will feel for the other person. There will also be a consideration of justice and of the other principles of ethics. And there will be an urge to help, to do whatever we can to help such an individual. So the humanities are the disciplines which will enable us, or which will help us to be better human beings, to be humane and humble and human. Now, what are the humanities? And experts on the subject, those who have studied these for a long, long time, have classified them into the branches of learning. So philosophy, history, ethics, anthropology, languages. Then there are the arts, literature, visual arts, such as painting, sculpture, and the performing arts, such as drama, dance, and films. And of course, there is humor. And humor, of course, enlivens everything and makes all kind of experience more rewarding. I now come to our goals as individuals who deal with patients. We may deal with them, as I said, as physicians, or we may deal with them as nurses or physiotherapists or occupational therapists, or in any other manner. Our goals are very simple. First of all, we are here to help our patients. And we are here to help our patients in every possible way. So if I restrict myself to the goal of a physician is not there just to help solve medical problems. If it is possible, the physician will also try and help economically, socially, and in every other way. Now, how can a physician help an individual economically? Most of our patients are extremely poor. We prescribe a test or we prescribe a medicine, and in many cases, the patient cannot afford this test or this medicine. And so it is possible for us to engage the services of a social worker and to try and obtain funds which can help the patient get that test done, or obtain the drugs that are prescribed, or carry out the procedure that is required, or undergo the surgery that is required. So it is possible for us as physicians not only to help as far as the medical problems are concerned, but in other manners. Here I've discussed how we can help them economically. As physicians, our primary goal is to relieve the patient of whatever symptoms brought them to us. Sometimes it is possible to cure the disease. And when that is possible, that is also our goal, to cure the disease, so that that patient never again suffers the symptoms and signs from that disease. But sometimes the disease is beyond our cure. Our medical knowledge is still limited, and we are certainly not gods. So there are times when we are faced with a patient who has an incurable disease. We cannot cure them. But because we cannot cure them, it doesn't mean we cannot help them. We can certainly care for them at all times. So say, for instance, there is a patient with advanced cancer, and this patient is in severe pain. It is possible for us to relieve that pain. It is possible for us to relieve other symptoms which the patient may have. So whilst we may not be able to cure the disease, we can certainly care for the patient and help in other ways. The humane physician must meet certain criteria. The first criterion, obviously, is that he has to be competent at his job. You can't be humane if you are an incompetent clinician or an incompetent physician or an incompetent surgeon. Next, you have to be ethical. Every act has to have the stamp of ethical activity, and you have to remain true to the principles of medical ethics at all times. This is not the time for us to go into the principles of medical ethics, but I think all of you know those principles, and we have to be guided by those principles at all times. It helps if we can also be inspired by the great doctors of the past. These doctors became great because of what they did for patients and on behalf to each of us, and help us to remain true to the patient and to remain true to the principles of being a humane physician. We should also be knowledgeable about the fact that we are dealing with human beings. And human beings are sometimes irrational, they are sometimes upset, they are sometimes angry, they are often worried about themselves and what will happen to them and to their families. So it is important for us to be conscious of these features which our patients will manifest from time to time. And so if you have an irritable patient, that patient may shout at you, the patient may even scream at you. But it does not mean that we shout in return and scream in return. If we are knowledgeable about what has driven him to be irritable, and if we try and get rid of that source of irritation, we will help the patient to return to the normal equanimity which we hope and expect from every one of us. Finally, the humane physician is truly worried about the patient and consequently about the family. The physician is worried about whether this patient's illness has been diagnosed correctly, about whether the treatment which is being given is effective, about whether the patient is improving or worsening. And if the patient is worsening, why is the patient worsening despite therapy? And then doing everything possible to reverse that worsening and put the patient back on the road to recovery. So these are the criteria which are encountered in the humane physician. And the physician who meets all these criteria and is shown to be excellent in every one of them is a true blessing as far as the patient and as far as the family goes. It is important also that we treat the person who comes to us, not just as a patient. And when we treat the person and not just as a patient, that means we treat the whole person. We treat not only the illness, but we treat any other problem that we can help to solve. We show the patient and the family that we are aware of the fact that we are lucky that we are not in the shoes of the patient, and we are aware of that fact. And because we are aware of that fact, we are going to do everything possible to help that person who has come with symptoms and with signs. I'm going to now show you a portrait which was made by a British artist in 1891. I feel this portrait contains the essence of the humane physician. Everything that is written about, talked about, discussed as regards humanity in medicine is encapsulated in this portrait that he has drawn. And he has entitled the portrait very simply, he has just called it The Doctor. Now let us try and analyze this painting in a little bit of detail. What is the doctor doing? The doctor is sitting patiently with no evidence whatsoever of any hurry. I have to go here, I have to go there, I have to do this, I have to do that. There is no trace of that. He's sitting patiently with his hand supporting his chin. And what is he looking at? He is looking at the sick child. He's looking at this sick child, and he has been looking at this sick child for many, many, many hours. He has been looking at this child probably for the entire night. Now, how do we know that? How do we know that he has been looking after this child for a long time and perhaps for the entire night? We know that because we can see over here that the light is on, which means that he must have come in when it was already very dark. On the other side of this room, we see that the sunlight is beginning to come in through the window, which means that dawn is breaking. So he has been sitting through the time when it was dark, and he's still sitting by the time when dawn is breaking. How do we still further recognize the fact that he's been sitting there for a long, long time? We can see this anxious mother. And this anxious mother who has been tense and who has been worried about her child, through sheer exhaustion, has gone to sleep. Not because her anxiety has disappeared, but because she's so tired, she's so exhausted that she has gone to sleep. But her husband, who is equally anxious and who is equally tense, as you can see from his face over here, is standing patiently and watching what the doctor is doing for the patient. What has the doctor done for the patient? The doctor has probably prepared some medicines in this utensil, which is there. He has probably ground some chemicals and prepared some liquid medicine with a medical suspension in it and has given it to the child. And he is waiting to see what the effect of this medicine is. You can also see indications of how medicine has been given to this child over here. You can see this bottle of medicine over here. So when you look at this portrait, what do you finally conclude? You conclude that this doctor has come to the home of a very poor patient. You can see from the surroundings of the child that this is a very humble home. It is not a palatial home. It is not a home for a well-to-do person. It is a home for a person who is of very humble means. So he has a relatively poor family in order to help in improve the condition of this sick child. He came probably late at night, maybe in the middle of the night, prepared, examined the patient, made his diagnosis, and prepared the treatment that he could give. And remember that we are talking of 1891, when pharmaceutical companies and ready-made drugs were not available. So he had to prepare his own medicines, which he has prepared over here. And he has given them to this child, probably spoon by spoon. The child is now gone to sleep, suggesting that the child is responding gradually, is not irritable, is not fretful, is not restless, but he is not yet satisfied. And so he is waiting and watching. And he has waited and watched the entire night. It is now dawn, and he's still showing no trace of hurry, no trace of anxiety, no trace of wanting to disappear to see other patients, certainly not to see any rich patients who may be waiting for him. So I think this painting actually shows us all the essentials of a humane doctor. He has come to a poor person's house knowing that he is not going to become rich by this consultation. He probably won't get any fees if the patient is very, very poor, but that doesn't seem to matter to him. He's quite prepared to treat this little child. He has spent hours and hours and hours watching the progress of this child and may continue to watch this child for another hour or two. And he is doing all this very, very patiently with no trace of anxiety and no trace of rushing away. So I think this is a portrait which we should engrave into our minds. And this is the kind of doctor that we should try to be. Here's a little bit about the artist, Sir Luke Fildes. This painting, we are told, was inspired by the death of his son in 1877 and by the devotion that was shown by the physician who looked after his son, Dr. Gustav Murray. This is what we learn when we try and trace the history of this painting. Dr. Murray displayed the quality of a physician which had been noted by a Jewish physician and philosopher of the 12th century. And this is what that Jewish philosopher Maimonides had said: "May I never see in a patient anything but a fellow creature in pain." Maimonides did not talk of poverty or riches. He did not talk of rewards. He did not talk of anything else. He said, all that I should see in a patient is that he is a fellow creature. He's a person like me. He's a human being who is in pain. And why should I see this person as a fellow creature in pain? So that I can do whatever I can in order to get rid of his pain and to make him happy once again. A generation after Fildes, there was in America a general physician, Francis Peabody. And Francis Peabody wrote an essay, a truly remarkable essay, which every one of us must study and take to heart. And he ended this essay with these words: one of the essential qualities of the physician is interest in humanity. Why should we be interested in humanity? Because the secret of the care of the patient is in caring for the patient. Here you have the essence of humanity distilled in one sentence by this great American physician, Francis Peabody. You will see the reference to Francis Peabody's paper over here. I'm just highlighting it. And I would very strongly recommend that you read this paper. If you don't read anything else which is in this list, do read this paper. It is a remarkable paper, and it will, if you take the lessons which he teaches us to heart, you will end up as a very good humane physician. The other books and references that I've put up are also very, very interesting and worth study. Sir William Osler was a Canadian physician. He eventually, he came to America and he was appointed the first professor of medicine at the Johns Hopkins Hospital in Baltimore. Eventually, he was appointed Regius Professor of Medicine in Oxford in England. Now, Regius Professor is an appointment which is made by the regent. That means either the king or the queen. So it's a regal appointment. And only one person can get such an appointment in Oxford, and one person can get such an appointment in Cambridge. So there is a Regius Professor of Medicine in Oxford, and there is a Regius Professor of Medicine in Cambridge. And you cannot apply for this post. They will select you, and then they will ask you whether you are willing to join. And so William Osler was asked whether he wished to join, and he joined. We are very fortunate in that William Osler was a wonderful speaker, a very, very literary physician. He was well versed in ancient literature, Greek, Roman, and other, and in modern literature of his time. He died in 1919. And he was requested to talk to medical students, nurses, general physicians, consultants, and he was very happy to do so. And fortunately for us, every single one of those talks was first written and then delivered. And the written version have been collected together and have been published as this book. Fortunately for us, you can download this book from this site. You don't have to even buy it. It's available for free. And it contains gems, absolute gems. There are lessons to be learned from this book which you will not find anywhere else. And every single essay reads the spirit of humanity. Very, very strongly recommended that you obtain this book and you study it and take those lessons to heart. And then, of course, there are other books which you might like to study, because each one in its own way teaches a lot. And each one of them helps us to become good, humane, and well-versed in the humanities. So I'm going to end this talk now and hand the microphone back to Dr. Kulkarni for further processing.
So thank you very much for that wonderful talk. And as we all often say, a picture speaks 1,000 words. With one picture, you were able to tell us so many aspects of that picture, which if you had not described, we would not have looked into it. And I think the same can be extrapolated to a patient also. A patient who walks in, his dressing, his smile or tears or his expressions, his body language, the way he walks in, each one helps us in identifying what the patient is going through. And it's just like interpreting a picture and trying to understand so many aspects about that patient. And I feel in the modern day practice, the doctors are spending very less time with the patient, where we really miss out on all these things. And thank you for bringing out so many aspects about a humane doctor-patient relationship. And with those thoughts, I feel we can go ahead with the interaction session. I request the audience, if you have any thing to share, if you want to share your experiences, or if you want to ask something to sir, you're free to do that. Anybody? So I would like to add that in the clinical ethics consultation course, which we have in the Center for Ethics, we have this one session on interpretation of images. So we go in groups of 3 or 4 students, and there are many beautiful paintings in the Yenepoya Medical College about different historical aspects of medicine. So we go there each one tries to interpret it. Sometimes we get totally opposite views, and then when we try to understand the interpreting images and expressions. Does anybody have anything? You can raise your hand or unmute your mic and go ahead with the questions.
I think this point which you have made about how we can learn from paintings and photographs and even movies, for that matter, is very, very important. And we are fortunate in that we have fair number of images of the great historical personalities of the past. And so, you know, if this group which you have formed was also to just take one historical figure from the past, say for instance, Charak or Sushrut. Unfortunately, we have no verified images of Charak and Sushrut because there has nothing been handed down to us from those times. Whatever we have are all imaginations of artists and imaginations of sculptors. But it doesn't matter, even if we take those illustrations and then we try and discuss the lives and works of these people, there is a lot to be learned. So I think you have started a very, very good activity, and I'm sure over time it will develop into a great resource.
Arvind Vaswani has a question to ask.
Yeah, I've already seen the books that you have recommended or the reading material that you recommended, but you did talk about there are good movies as examples. Could you give us a few examples?
Have you seen a movie called The Wit?
No.
W-I-T, Wit.
Okay.
It is a Hollywood movie.
Okay.
And it is about a professor of literature.
Okay.
An American professor of English literature.
Okay.
And this lady has specialized in the works of John Donne.
Okay.
I'm sure you're familiar with John Donne, D-O-N-N-E, John
Yes,
Donne.
I think, yes.
John Donne wrote that famous poem which has these lines, "Ask not for whom the bell tolls, it tolls for thee."
Right.
Remember those lines?
Yes.
So those are just two lines from the large number of works that John Donne had written.
Right.
And this lady teaches John Donne's works to her students. Her own teacher, this professor's teacher, who had taught her English literature, was also a specialist in John Donne. And so she had learned a lot about John Donne and his works from her teacher. Now, this lady develops cancer of the breast. And so she is admitted to hospital. And how she is treated in the hospital is the substance of the entire film. First of all, she's made part of a research project. And she's literally treated like a guinea pig. Then she issues, as her disease progresses and as she knows that she's dying, she writes out a living will. And when she actually collapses, none of the doctors bother about her living will and try to intubate her and do all kinds of crazy things to her. And it is a black nursing sister who reminds everybody else, look, she has said she doesn't want all these things. So it's a film which has many aspects of what is wrong in the practice of medicine, medical research, medical education. It's a very, very thought-provoking film, and the acting is absolutely superb. So I think if you haven't had a chance to see this, you will probably enjoy this, and your students and your residents will learn a lot from this film.
Okay, thank you. Thank you so much.
Understanding, or what is your impression about use of poetry and other forms in teaching medical students humanities?
The literature as a whole and poetry in particular have a huge role to play in many, many ways. The first is most of us as medical students, unfortunately for us, most of us are woefully ignorant of literature and of poetry. That is not surprising because all effort is concentrated on getting numbers, on getting 99 out of 100 and if possible 101 out of 100 marks in every subject. So every effort is tailored only into this particular channel. And that leaves no time for literature, for poetry, philosophy, of any of these enriching areas. Now, literature, you might, I mean, an ordinary individual might suppose had nothing to offer medicine, which is very, very wrong. Of both ways, there are great literary experts who have written about their own illnesses, their own experiences with pain and suffering, and experiences of pain and suffering in friends, relatives, and so on. And there is a lot to be learned from that. There are eminent doctors who have written books about their patients, about their experiences. A very common and very simple example of such books are the books written by A.J. Cronin, C-R-O-N-I-N. I mean, that is just a very simple and obvious example, but there are many, many others. Now, if literature is thought-provoking, poetry is encapsulated literature. Poetry in 2 lines tells you what an essay tells you in 100 lines, because it is so beautifully concentrated and it is put so nicely and concisely that in a short poem, the poet conveys more than what an essay can convey in a long essay. And it is conveyed in a very subtle form and in a very thought-provoking form. So I think you're absolutely correct. There is a lot that medical students, residents, and all of us as physicians can learn from literature in particular, and poetry literature in general and poetry in particular, which will not only enrich our lives, but which will make us humane, better, ethical physicians.
Can I add to that, sir, Dr. Pandya?
Yes.
Yeah, I totally agree 100%, because as a medical student too, I read a lot of medical mysteries, but then it also, not only the mysteries, but that from Lawrence Sanders, Henry Denker, which made us re-look at how the healthcare delivery elsewhere worked, and how was the gap between the rich and the poor, and what efforts were made by some to bridge while others totally hid it under the carpet. That is a time where it gives a lot of introspection. As a student, a medical student, you cannot stop thinking of the hard things. It's not just you come across patient and doctor and you have learned in the clinic, but where is your value as opposed to that? And if you're reading the right literature, it then takes you on the right path. So I totally agree with you that as students, it's not enough for us just to read what is in the text, but also oppose your viewpoints as to is it right from wrong? And what do I need? And do I have the right answers? Because we stop questioning ourselves on any of these quests. We go back to what's called the Nuremberg defense. We do something because my authority tells us, my boss has told me, the system tells me. So even if you put the poor man out for somewhere because he didn't get money, there are some who still have within them an intuitive instinct to go and get them and help them. Whereas rest of them say, if the system doesn't permit, what can I do? So I think a lot of rethinking, realigning ourselves to the values comes through introspection and reflection. So I think it's a very wonderful way, the way you quoted the movies as well as the literature and the poetry, because we in PG Diploma Bioethics, we have a host of movies we show, more so in case of clinical ethics, including Ship of Theseus, 12 Angry Men, and especially of late, I was quite impressed by that movie, Children Act, about the Jehovah's Witness and other things. So we do reflect upon the movies, and it's easier for us through reflection to reach a viewpoint than when asked by us, what is your opinion? Then we give an intuitive explanation. So I think the movies, the literature, and the imagery has a huge impact on a person who wants.
Yes, I think you're absolutely correct. Has your sound died?
No, I can hear you, sir. I can hear you, sir.
Okay. I think you're quite right. One problem which has been discussed, not just in India, but even abroad as well, is when should this concept be introduced into the curriculum? And the consensus opinion is that it should be introduced at home. It should be introduced whilst that person is still a child. And so every home must start off by embedding this culture of literature, of philosophy, of religion perhaps, of thinking on behalf of the other person. How can I help the other person? Trying to help others instead of all the time thinking only of ourselves. And this should be introduced at a very, very early age, because by the time the student reaches the 10th standard, as I pointed out, unfortunately, our system and all other important educational activities get thrown by the wayside. I'm just looking at the chat, and I find that Dr. Animesh Jain has asked, what are your views on what we commonly hear or notice in the present teachers? They feel that the students will learn themselves. Also, there are no role models, so it doesn't work. Besides, the 8Com module suffers from a challenge where faculty is not equipped with the skills and knowledge to teach and inculcate these values and professionalism in students. This is an important point. It's a very important point, because many years ago, we used to conduct workshops in different parts of India. Some of them were half-day workshops, some of them were 1.5-day workshops. They were conducted usually over the weekends. And because Saturday afternoon and because the whole of Sunday is free, we used to concentrate on that area. And the program, when it was coming to an end, would have a session of about 2 hours, which was meant for questions and answers. And one of the common questions that was asked, almost at every single session that we conducted, whether it was in Tamil Nadu or whether it was in Bengal or whether it was in Delhi, the question that was asked was identical. You over this half day or 1.5 day or whatever, you have taught us about, or you have discussed with us medical ethics, and you have discussed with us humanities, and you have discussed how patients should be given rights, etc., etc., etc. Why has this never been taught to us during our undergraduate curriculum? This was a common question. And so it was very obvious that the curriculum as it existed did not give time for the discussion of such topics. And so for these youngsters, this was a revelation. Our half-day workshop or 1.5-day workshop was a complete revelation. The point made about role models is also extremely important. See, medical students are amongst the most intelligent of students. They would never have entered medical college unless they were intelligent. They've got 98% marks, 99% marks, 100% marks. They are highly intelligent. We can go on talking to them about humanity, about ethics, about all these things till the cows come home. We can go on talking to them. But if after giving a lecture on ethics, if I go out and in the outpatient clinic of a general hospital, I shout at a poor patient, that student is not going to go by what I told him. He's going to go by what he has seen me do. And therefore, this role model is an extremely important concept. It is only when all teachers show by example that this is medical ethics, this is humanity, this is how we should behave with patients, this is how we tell a patient's family that your patient, unfortunately, in spite of all our treatment, is dying. When he sees how we deal with this in practice, that is what will impress the student. Not the talks, not the symposia, not the lectures, not anything else. So this point made about the role model is an excellent point, and I think many of us as teachers need to sharpen the manner in which we behave with patients, particularly when students are around. But we should be behaving with them in the ideal manner all the time.
Thank you so much, sir. Thank you so much.
Any other points? So there's one.
Mr. Dr. Syed Mohammed has just written a comment. We are lacking relationship ethics with our own colleagues everywhere. Competition by suppressing colleague for financial benefits, not for serving society and patients. This is about the worst manner in which we can practice medicine. Because by this method of practice, first of all, we are showing that we don't really care about the patient. Secondly, we don't care about our colleagues and we try and run them down. Why are we doing all this? So that we can attract more and more patients to ourselves and so that we can become richer and richer and richer. This is absolutely the wrong motive for us to be in the medical profession. If we wanted to become richer and richer and richer, if we wanted to be multi-billionaires, we should have gone into stockbroking, or we should have gone into becoming the managing director of a big company, or we should be trading in bitcoins, which are the current fashionable way of getting rich. Medicine is the wrong profession to get rich. Medicine is a profession where you can live comfortably on the basis of the earning that you make. And that is all that you can do. You cannot get 3 Mercedes Benzes, 6 flats in different parts of the country, all of them 4-bedroom, fully air conditioned. You can't. That is not what medicine gives you. But what medicine does give you, after you have practiced medicine the way you should be practicing, is it gives you peace of mind. That when you go to sleep at night, you sleep easily. You just put your head on the pillow and you're fast asleep. Because you have no anxieties, you have no tensions, and you have the satisfaction of having tried to help in your own way your poor patients who came to you. So this running down colleagues is absolutely to be condemned. Now, that brings me, may I just digress a little bit, Dr. Kulkarni? I'm just going to divert a little bit. we often have to refer patients for the making use of the expertise of somebody else. So for instance, suppose I am a neurosurgeon, but I have a patient who is going into cardiac failure. And I'm not a cardiologist. I'm not anywhere near qualified to treat a patient with cardiac failure. So I have to seek the help of a good cardiac physician. How do I refer this patient to that cardiac physician? And there is an established ethical manner in which I can refer this patient. The first thing I have to do is I have to write down a summary of this patient's clinical history and findings. Then I have to write down the reason why I'm referring this patient to the cardiologist. With my diagnosis, although I'm not a cardiologist, I feel that this cardiac failure is because of ABC. Because you are much better than me at dealing with these, and because I'm worried and concerned about my patient, I shall be grateful if you could please examine the patient and take over the treatment of this patient's cardiac problems. That is the way we should refer the patient. In the olden days, when I was a medical student, if we had to refer a patient, we had to ensure that when the consultant comes to see the patient, because of our request, we are there, present there with the patient. So that in case that consultant wants to ask certain questions, get some clarifications, resolve some doubts, he can do it instantly. So it was important that we ourselves should be there when that consultant comes to see the patient. We treat that consultant with all the respect that is due to him in front of the patient and in front of the family. Let the family know that we respect this individual whose expert opinion we have asked for. Finally, we have asked for that person's help. He didn't tell us, you refer a patient to me. So it is our duty then to follow the advice that the consultant has given and then give him a feedback. Thanks to the treatment that you had advised, this patient has improved, all this cardiac failure has disappeared, and the patient is now well. And I'm going to refer this patient to you for continued care as far as the heart is concerned. And could you please take over? Now, what is the practice these days? I will tell you of an example that was narrated to me, first-hand example. This is not second. There is a young ENT surgeon. This young ENT surgeon had a patient who needed a somewhat complicated ear operation. Because this was a complicated ear operation, and because he was young and he was just starting out, he referred this patient to a senior ENT surgeon for opinion and advice. He merely wanted opinion and advice. And he wrote that, I feel that this is the diagnosis. I feel that this operation is necessary. Will you please examine and inform me about what you think should be done? The next thing he knew, that consultant had admitted that patient under his care, done the operation, finished. Everything is over. He had only sent him for an opinion. He only wanted confirmation that what he was saying was right. And he wanted the patient's family and the patient to know that you're not making a mistake and you're not making a frivolous statement when he said an operation is necessary. Instead of which, that consultant went ahead and did the operation and finished, everything is over. This is not the way we behave with younger consultants who are referring patients to us. There's one more comment which has come. Doctors do not have time to talk to patients and to take a proper history in spite of the number of tests available to them. Gone are the days when the doctor used to diagnose the patient just by taking the history of the patient and by observing the patient. This is very, very true and very, very sad. There is now, in 1974, at Queen Square, which is the big neurological hospital of Britain, situated in London, at Queen Square, they had the second CT scanner installed, the second CT brain scanner. The first scanner was installed at Atkinson Morley's Hospital, and the second CT scanner was installed at Queen Square. I was there 74, 75 as a Commonwealth scholar. I was a student, observer, shall we say. And the professor of imaging, because the word radiology had gone, now that scanning was available. And later on, of course, once magnetic resonance scanning came, then there was no radiation involved, so that term radiology disappeared and it became imaging. The professor of radiology there, his name was Dr. George Duboulay. When he started talking to us about neuroradiology, the first sentence he said was, "I am very sad that the CT scanner has been invented." Can you imagine? I mean, this is the first machine which helps us to look inside a living brain. We could never see the inside of a living brain. Now you can see everything: cerebrum, cerebellum, brainstem, blood vessels, CSF, ventricle, everything. And he said, "I'm very sorry that this machine was invented." Why did he say this? He said, "I foresee," this was in 1975, 1 year after the CT scanner had come into Queen Square, "I foresee the day when people will ask for a CT scan without examining the patient. Clinical medicine will atrophy." And that is why I feel that this machine is a very sad invention. I mean, he was not running down the machine. He was issuing a cautionary note. Unfortunately for us, what he said has proven to be absolutely correct. And what Dr. Deepa Pradhan has said, no, Dr. Syed Deepa Pradhan has said is absolutely correct, that we are now replacing or substituting tests for clinical acumen. It is ridiculous to say that I do not have time to take a good history. It is ridiculous. We have to find time to take a good history. If you have so many patients that you cannot take a good history, then share those patients with your colleagues. Get other people involved in taking the history for you. But you can't say, "I have no time and therefore I'm not going to bother about the history." Because 90% of the diagnosis is made from history. Only 10% is made by clinical examination, or 8%, and maybe 1 or 2% by investigation. Investigations usually are only to confirm your clinical diagnosis and to make sure you're not making a mistake. You cannot substitute tests for clinical acumen. Clinical acumen has to remain supreme. Unfortunately for us, throughout our country today, clinical acumen is going down the drain. And it is not uncommon for a patient to phone a consultant, say for instance a neurosurgeon, and say, "Doc, I want to come and see you." And what does the neurosurgeon say? "What is your problem?" So he's saying, "Sir, I've got headaches and I'm feeling a bit nauseous." Okay, you do one thing. Go to so-and-so CT scan center, specific CT scan center. Go to so-and-so CT scan center, get a CT scan done, and get those films and come and see me at my consulting room at 6 o'clock tomorrow evening. He has not even examined the patient. And he's already telling him, "Go and get a CT scan done." Worse than that, he's telling him, "Go to this particular CT scan center," which straight away raises a problem about whether he's getting a cut fee from that CT scan center. Now, why is this wrong? Why is it wrong to ask for a CT scan without even examining the patient? Because in this particular case, the CT scan is completely normal. Now, what do? He has come to your clinic and the CT scan is normal. You have made him spend God knows how much money, 1,500, 3,000, whatever the CT scan rate is in your sent in your clinic or in your hospital or in your city. So he has wasted this money. When you now get down to examining him, you find that his blood pressure is 280 by 160. So what have you done? First of all, you didn't bother to examine. You didn't detect his high blood pressure, which is the cause of his headaches. And you made him waste his money on a CT scan, which was totally unnecessary. This is one of the reasons why it is stupid, it is ridiculous, it is bad medicine to get tests done before you have taken a good history and before you have examined the patient. I think Dr. Deepa Pradhan has made a very important point over here. There's one more comment which has come up, and that is the referring specialists get offended if the primary physician does not follow all the instructions written by the expert. While it is good to take the advice of the expert, is it mandatory? The primary physician has an overall picture of the patient better than any subspecialist. This is from Dr. Ravi Vaswani. I told you when I started discussing this that the old time practice was that when we refer a patient to somebody, particularly if it's an inpatient, then we make sure that we are there when that physician comes for the consultation. If we are there when he comes for the consultation, so many things can be straight away sorted out. That consulting physician whom we have requested asks some questions, clarifies his doubts. Because you know more about the patient, you can tell him, no, I think this is not true. This is what the actual facts are. This is the history. These are the findings, etc., etc. And so many things can be sorted out. But let us assume that there is a genuine disagreement. The referring physician asks you to give ABC treatment or perform XYZ test, and you believe, no, that is not the right thing, that's a wrong thing, and there's a mistake that he is making. You have two options. One is to confess that you made a mistake in selecting this person to be the consultant, okay? With your best intentions, you thought he was good, but obviously you're not good. He made a mistake. Only route now available to you is to treat a second opinion. You have got one opinion, that person has given you his opinion, advice, everything. You are having a conflict with that. You get a completely different expert, more or less of the same eminence or even greater eminence if possible, and get that person's opinion. With two opinions, you can't go wrong. You know, by now you will know what is right and what is wrong. And then you follow your conscience, whatever you think is correct and best for the patient, you do. So this is how I would solve the problem of the consultant who comes as an expert because of my request. I find that if I'm present when that consultant comes, 99% of the problems can get resolved. Because whatever doubts that person has, that person expresses the doubt, I do my best to clear those doubts. And at the end of the consultation, we have a meeting of minds. We have already discussed all the pros and cons, and we come at a common, agreed upon line of either investigation or of treatment. And even for the patient and for the family, that is good, because they can see that the two of us are in agreement when we recommend either some tests or when we recommend some treatment. And this was the traditional standard practice in the old days. The trouble is today everyone thinks that he is too busy. The referring physician also feels that I am too busy. Let him come and see the patient. Why should I be there? And the person who is called upon as an expert, he also says, I will come at time that is convenient to me. I'm not going to come at a time which is convenient to the guy who has referred the patient to me. I'm a very busy person. So everyone is very busy. Now, if everyone is very busy, then it's very difficult to find a meeting ground. And that is why many of these problems arise. Many of these problems are actually problems of ego. They are not problems of medicine.
Thank you, sir. I think one way of teaching a doctor the most appropriate human doctor-patient relationship, it happens when the doctor falls ill. So when the doctor becomes a patient, I think that is the time when he understands why doctors are not treating me, why doctors are not talking to me, why are they asking for so many investigations. I think that is when a doctor learns more about the good doctor-patient relationship when he or she becomes a patient. So I think with that, I think most of the questions are also over. It was a wonderful talk, sir. I hand over to Dr. Parvata Vardini Gopalakrishnan for vote of thanks.
Tell them that the certificates will be issued.
Thank you, Dr. Uma Kulkarni. On behalf of the Mulya Pravah Task Force and the Center of Ethics for Ethics from the Yenepoya deemed to be University, I extend a warm and sincere thank you and gratitude to the speaker, Dr. Sunil K. Pandya. I will take my time to expand a little later, but I would also like to extend a warm gratitude to our Registrar, Dr. Gangadhara Saumyaji. I would like to thank Dr. Leena Casey, the principal of the Yenepoya Nursing College. I would like to thank Dr. Rochelle Tellis. She's Professor YMC. Dr. Uma Kulkarni, of course, I've already thanked you and for being the wonderful founder and the organizer of the event. I would like to thank Dr. Hari Kishore Bhatt. And last but not the least, Dr. Veena Vaswani of the Center for Ethics. I'm coming back to thanking in person and gratitude for the wonderful, excellent message given by Dr. Sunil K. Pandya. For me, this is the first experience with listening to ethics in medicine. And I'm extremely grateful to your eloquence, your articulation, your logical sequencing in such a simple manner, beginning with the period of Hippocrates and the history of how medicine originated, also giving us beautiful examples of how a portrait expresses compassion, care, and healing from the times almost a century ago. And then a beautiful conclusion to how the modern world looks at care and healing, where even some ethical doctors do not like the invention of a CT scanner, the example that you beautifully gave. This entire hour and a half really is a great inspiration as how in an injured world today, how healing can take place if each and every healthcare worker looks at his little contribution to the way he can deal morally and ethically at each individually touch point and hotspot he has with the patient, or the relationship with not only the patient's family also. The portrait gave you the image of a child, the mother, the father, and the doctor. So most of the times, as we worry about patients, we also do ignore the relation, the people around the patient. So this beautiful conclusion of how doctors should also understand literature and poetry and humor and humanity is something that is a beautiful message that I've heard from you, sir, today. And I would like to conclude with this beautiful statement that you already have put up in your slides. May I never see a patient anything but a fellow creature in pain. So I think your entire message is summarized with only when you're in pain, you'll understand how you would like another person to treat you when you're in pain. Thank you very much, sir. I also would like to personally, extend a very warm gratitude for you having put up the first few slides where you have mentioned our university as part of the universities following ethical procedures and have a system in place for ethical procedures. I would also like to thank the IT department for their extensive support, because the voice was so clear, the images are clear, we could hear you beautifully, and we could see you well, and that's how I would like to conclude. Thank you very much, Dr. Pandy, and we would like to see you more and more often and hear you often.
Thank you, sir.
Thank you very much.
Thank you, sir. Yeah, with this we conclude.